right, good morning again, everyone. I'm Mark McClellan. I'm the director of the Engelberg Center here at the Brookings Institution. I'd like to welcome you all to Brookings this morning to our event on Health IT in an Era of Accountable Care, an update from the Beacon communities. We are very pleased to be hosting this event in coordination with the Office of the National Coordinator for Health IT. And I also want to thank the Milbank Foundation for their generous support for this event. And especially I want to thank all of you who have made the time to come here today. And many of you in the room I know are people who are making a lot of contributions to improving care and lowering costs and helping to use Health IT effectively to do it. In addition, I want to thank everybody who's joining us today via the webcast who are with us online. And it is an important time. We are meeting today 1 year since the launch of the Beacon Communities program. As many of you know, this is a community-based set of initiatives supported by the Office of the National Coordinator for Health IT with the goal of illustrating how to use IT in support of ongoing improvements in healthcare. Not IT for an end in itself, important as information technology can be, but aiming to demonstrate how, at a community-based level, these systems can be adopted effectively to create what many hope will become the new normal in healthcare, a way of delivering care that relies on what information technology has to offer, that makes use of its many advantages and addresses some of the challenges in IT adoption. In addition to giving the Beacon communities a chance to highlight what they've been working on over the past year, we also hope to talk together about the lessons learned, the long-term goals, and the further steps needed to achieve them. We're going to look at how the implementation of Health IT in the Beacon communities has been affecting the quality of care thus far, what some of the challenges and next step opportunities are, and the related improvements in healthcare delivery and in healthcare financing and other policies that may be needed to further increase the coordination and accountability of care. Again, the goal is on better care and avoiding unnecessary costs. In working towards this goal, the Beacon communities are seeking to strengthen the local capacity, again this is all locally led efforts, to achieve significant improvements in the way that care is delivered. In the course of doing that, over the longer term, they've been working to identify specific steps, step-by-step progress that they can make to identify progress in the short term as well. And in the course of making these changes, they're developing a much stronger experience base on what kinds of innovations work in Health IT, but also in measurement technology and delivery strategies that go along with the Health IT changes, and in many other ways. They are making a lot of progress, and that's one of the things that we want to talk about today. Where are they now on their journey? What can we expect them to accomplish in the coming year? What are the lessons? Also, they have a lot of work to do. Where are they headed? What are the challenges to making the efforts that they're undertaking now sustainable, to making it part of a new normal, a new way of delivering care? These kinds of changes are not always easy. When our financing system, for example, often rewards the volume and intensity of care, and organizations that invest in Health IT, at least historically, have often been penalized financially for doing so. It can be more difficult to sustain those kinds of efforts as a result. The Beacon communities and our many other healthcare policies are taking steps to change that, and we want to take stock of where we are with those efforts around sustainability as well. And then looking forward, what are the implications for where we go from here? What does the increasing adoption and meaningful use of Health IT and the expansion of provider payment reforms to support these kinds of initiatives mean for the future of healthcare? Is it going to help us really get to sustainability, not just of using Health IT, but of our overall healthcare system, and what kind of further steps are possible in the short term? Today, in pursuing these kinds of questions, we're going to hear from three different sets of panelists. The first, which I'm very excited to be a part of, is going to give us a comprehensive look at the current federal Health IT strategy. The next panel which is comprised of Beacon community representatives, will talk about the priorities for health system improvement and how they're going about accomplishing them in the Beacon communities. And then the final panel, which is also comprised of Beacon community leaders, we'll talk about the crucial role of health IT in payment reform and other steps towards sustainability of these reforms. So that's a bit of an overview for the day. Each of the panel sessions is going to lead off with a short overview of some of the key issues through brief presentations by each of our panelists, and we're going to keep this all informal so that we're focusing on things that are happening here and now and making this as much of a dialogue and discussion as possible. After all the panelists have presented, we're going to have some further discussion involving all of you, where we'll have about 10 minutes at the end of each panel for questions from you. Here in the room, there are going to be roaming microphones. So when you do have a question, please raise your hand so that our mic runners will know to come and call on you. So with that, we're going to get started. I'd like to invite up to the stage the panelists for our first session, our keynote session on an update on the federal health IT strategy, and we have the people here who are best qualified to do that. That includes Aneesh Chopra, the United States Chief Technology Officer, who in this role serves as, and yeah, you guys can sit wherever you please. I don't know how you guys like to sort yourselves out, but please go right ahead. Aneesh works to advance the President's technology agenda through new ideas and encouraging government-wide coordination to help the country meet its goals, from job creation to reducing healthcare costs to protecting the homeland. And he has a very, I think, quite unique strategy in how he goes about doing that. It's great to have him here with us. He started in this job on May 22nd, 2009. Before that, he served as the Secretary of Technology for the Commonwealth of Virginia from 2006 until 2009. Also with us on the far end from me is Joe McCannon. He's Senior Advisor to the Administrator at the Centers for Medicare and Medicaid Services. Prior to that, he was Vice President and faculty on dissemination and large-scale health improvement at the Institute for Healthcare Improvement. He worked at IHI from 2001, where he led organizational efforts to spread change in Africa, the United States, and other regions of the world. Closest to me, Dr. Farzad Mostashari serves as the National Coordinator for Health Information Technology within the Office of the ONC at the Department of Health and Human Services. Dr. Mostashari joined ONC in July 2009 as Deputy National Coordinator for Programs and Policy. During his tenure in this position, I know many of you got to know him better, his office established several major grant programs geared toward fostering innovation, increasing health IT adoption, and the meaningful use of information technology, and support for health IT workforce development. He and his team also chartered and conducted numerous meetings of the federal advisory committees, developed and issued final regulations on technology standards and the temporary certification of EHR technology, developed the federal health IT strategic plan, and coordinated closely with CMS to define and help to implement meaningful use for the CMS electronic health records incentive programs, which is out there right now. So very pleased to have all of you with us today. And Aneesh, maybe we could start with you for some opening comments on where we are on the federal health IT strategy.
Thank you very much for having me, and happy birthday to the Beacon family that's sitting out there in the audience and watching us on the webcast. I will basically summarize my remarks in three pieces. The first piece is to begin with how the President views these issues. In September of 2009, he unveiled a strategy for American innovation. And in that strategy, he outlined three particular roles for government. It starts with our investments in the building blocks of innovation, and that historically had been research and development expenditures, investments in the workforce for science, technology, engineering, and mathematics as emphasis, and in the context of the discussion today, investments in our infrastructure, yes, physical, roadways, railways, and runways, but increasingly now digital. And that's where you saw the President in the State of the Union specifically reference a new initiative to achieve widespread adoption of fourth-generation mobile broadband services throughout the United States. In fact, a strategy to unleash hundreds of billions of dollars of economic growth born on the value of the airwaves that we think will fuel applications like, as the President said in the State of the Union, face-to-face video chats between patients and doctors. The second pillar of the strategy for American innovation has been the emphasis on the market conditions that spur entrepreneurship and innovation. Here, the President turned to his trusted advisors externally, led by Steve Case, who serves, yes, on the President's Jobs Council, but also is chairman of the board for Startup America Partnership, to catalyze and inspire entrepreneurs to enter this market. We see significant economic opportunities in the health marketplace, delivering the products and services that will fuel the kinds of quality improvement, cost-saving items that these beacon communities will represent. And then last but certainly not least, he unveiled an outline of a handful of topic areas where he felt the country needs an all-hands-on-deck approach. He referred to this as catalyzing breakthroughs in key national priorities, including unleashing a clean energy economy, and for the purposes of today's discussion, harnessing the power of health information technology as a platform for delivering the kind of care delivery reforms that we are very much excited about and witnessing firsthand in these beacon communities. That strategy, for a moment, on the health piece emphasizes two very interesting trends. The first trend, as our dear friend and colleague across HHS from the tech and innovation side, Todd Park, often says, the power of data liberation. The president, on his first full day in office, changed the tenor of Washington by emphasizing a more open and transparent government. So we've been liberating information in the government's coffers basically since that first day. It was my first homework assignment, actually, to put in place the policy framework to encourage more of that data liberation. But in healthcare, not only are we liberating information that had previously been held inside Washington, we're actually, through the Affordable Care Act and the work that's been done in the HITECH Act, actually liberating information that's heretofore been held by other institutions, whether it be hospitals, providers, insurance companies, and other stakeholders. So liberating information gives us this platform for identifying where are the high-risk patients and how might we get the services that they need in advance so that they can be treated hopefully in a more in a wellness-oriented fashion. You'll hear more about that momentarily. But it's also about the incentives, and you'll hear Farzad and my brothers and sisters, not only at CMS but also throughout the day. The big theme you're going to hear is going to be around how we've shifted the incentive structure in healthcare, probably the single biggest policy lever to address care delivery transformation. As we shift from volume to value, we now will see a new marketplace open up that will consume all of this data liquidity that we talked about and put it to use in the way that the market will reward, because it will emphasize applications and services for the purposes of keeping you healthy and improving the health performance of our and the financial performance of our healthcare system. I say that in the context of what we're doing today in Beacon, because the Beacon communities are very much the name, as it suggests. They are the test beds and the innovation labs for some of what this new world will look like. In fact, today, we're very excited to announce, as an example of some of this activity, the Centers for Disease Control, in collaboration with the Office of the National Coordinator and the Beacon communities in North Carolina, are partnering with a startup called Asmopolis, who will establish a very simple and interesting proposition that for folks who've been admitted to the hospital with asthma, upon discharge, can enroll in a very simple 4-week text messaging and outreach program so that we can follow individuals upon discharge and ensure that they don't suffer enough to require them to be readmitted into the program. And it's not just about the text messaging or thinking about using the new tools for communication, discharge instructions in a new and creative way and the like that we'll see as an innovation, but it's also about enrolling roughly 2,000 of the folks in the community in North Carolina in a program that Asmopolis will run to actually harness new information that has heretofore not been collected in healthcare. In fact, they've got a very interesting little application. When an asthma patient literally depresses their inhaler, it will record the GPS position and the time so that you can look at patterns to see, are there some themes that would recommend to you, you might want to avoid this time of day around this location, because that actually is an environmental factor that is going to lead to your likely hitting some kind of uncontrollable asthma attack. This very interesting and innovative proposition will be demonstrated in a test scale, if you will, in North Carolina. And as we all know, the purpose of innovation is to sort of identify these new ideas, test and validate them, and then my brothers and sisters to the right and left will scale what works. Final observation, This concept of this example that I've just referenced, the story of Asmapolis and its relationship to the beacons, is really a challenge and a call to arms to all the beacons in this room today. You will be the epicenter for where these new products and services will come to market that will be, in my humble opinion, the next billion-dollar enterprise. But they'll be the next billion-dollar enterprise because they will have worked with you to achieve the quality goals that all of you have told the American people are critical to the success in your communities. So how we use this opportunity to connect the beacons to innovators to solve those outcomes goals is going to be one of the exciting stories, Mark, in the coming months. With that, I'll turn it over to Farzad,
I think.
if I may, for the next round of dialogue.
Great.
So a lot has happened in the past couple of years to change the context within which these conversations are taking place. The Health IT was probably the first out of the chute in terms of the passage of the HITECH Act and the ability here for us at ONC to begin to support a wide-scale transformation in healthcare. Whether it's the payments, incentive payments that for eligible physicians and hospitals, which this month we're going to have the first payments going out for meaningful use, which is going to be wonderful, I think, validation of the efforts that so many providers and hospitals have made in moving ahead. But also the support structures in the form of the regional extension centers for the process redesign and the assisting particularly smaller practices. We now have 67,000 primary care providers working with extension centers. That's probably 100 million patients whose care will be directly improved. It's working with states to establish the infrastructure for information exchange. It's creating research and development programs, community college workforce program, which graduated over 2,000 HIT graduates last month, and we're going to be moving towards 10,000 graduates a year to meet the needs and jobs in that marketplace. But so a lot happened in the past couple of years that in some ways goes unnoticed. But we always knew that if it was just the Health IT, we would never succeed in truly creating the conditions for improved health and healthcare for all Americans. And then what happened was the Affordable Care Act. And that really brought all the pieces together, where we finally had not just hints, but actual tangible progress. And I think across the country now, there's nobody who would question that no matter what form it takes, whether it's bundled payments, whether it's pioneer ACOs, whether it's the whatever the final rule around accountable care comes, the shared savings, whether it's partial cap, whether it's patient-centered medical homes, there is no longer any question that we will be moving to healthcare financing that rewards value over volume, as Aneesh said. That's going to happen, and that, I think, creates this alignment and potentially a virtuous cycle between the information tools that people need in order to be able to improve quality, safety, efficiency, patient-centeredness, care coordination. The practice redesign and process redesign necessary to implement that, and the payment to make it all go round and round. And better information systems enable smarter payment. And smarter payment then creates the context for the process, the investments in process change and IT needed, and so we go. So what will the future bring? I think as we look ahead, and I think the beacons are that microcosm of the future, we needed a few things to happen. We needed to set goals and focus public attention and clinical attention on a few things that really matter. That's what a strategy is focusing attention on what you're going to do And what are you going to prioritize? And that's a really hard thing to do because every time, right, you all know that. You all know that you can't get anything done unless you focus. But every time you focus on one thing, there's 10 things you're not focusing on. And you're going to hear from those 10 stakeholders. Why aren't you focusing on this? It's an incredibly hard thing to do, right? You beacons in the audience know that. But you have to do it. You have to bring focus. And we've done that nationally with the National Quality Strategy. We've done that nationally with the Partnership for Patients that said there's a lot of really important things for us all to work on. But how about two whose time is past? Why don't we reduce readmissions by 20%? Why don't we reduce hospital safety events by 40%? Those are the kinds of crisp goals that you can then mobilize around, focus around, build coalitions around, create attention around, and then build your systems backwards. What is it that I need to accomplish that? Instead of, let's just create infrastructure for the sake of infrastructure, technology for the sake of technology. And it's a strange thing, sometimes I think, get surprised, the National Coordinator for Health IT, and I say it's not about the technology, right? It's about what we're going to do with the technology. And I think that is one lesson that the Beacon communities truly exemplify. The second thing we need to do is we need to bring help to providers who want to make the change. And I think one of the things that has struck me is, there's a lot of people who feel upset now that for whatever, the ACO rule comes out and they say, well, it's too hard for me to participate in this. And that's such a wonderful problem for us to have, because what it says is that there is a thirst and a hunger out there among all types of groups, whether it's the largest integrated delivery networks or the networks of primary care providers that are in some of our Beacon communities, or local community hospitals who say, we want to change. Not only do we see that we have to change, but we want to change. We want to be able to deliver care that's truly patient-centered. And we yearn for the opportunity to not go broke doing that, for that to help us compete. But it's going to take hard work, particularly for some of those who haven't been doing this for 10 years, who aren't the largest integrated delivery networks. They're going to need support. They're going to need technical assistance. They're going to need a helping hand. And I think that's the other part of what we're doing with the Beacon communities on the process redesign and what the extension centers have done. We spent a lot of time putting technology and effort, and a lot of folks here, the rate of basic EHR adoption has gone from 20% among primary care providers to 30% in 1 year, 2009 to 2010. If that keeps going, we'll be over the 50% mark next year. That's a true tipping point. But that's just the piano, right? Now you have the piano in the office. And the piano now, because of our certification program, has all the keys you can press, right? Here's the CDSS key, blink, blink, blink. Here's the registry key, blink, 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 right? But that's not music. People need to learn to play the piano, put the chords together, right? How does the med list and the problem list go together with the vitals and the smoking status in support of decision support? They need to be able to play the music. And many of you out there have been playing beautiful music, beautiful music. And if we think about what it is that an accountable care organization, however you structure it, is going to need to do. If you think about, you need to be able to know your patients, right? You need to be able to make a list, for crying out loud, of the patients who need to be reached out to. People who we are collectively failing. We need to be able to put that list together. But it's not as simple as right? You can't, first of all, you can't possibly do that with a room full of paper charts. You can't possibly do it. But second of all, there's a lot of work that goes into being able to do that, right? You have to collect the data in the right place, in the right way. You have to have process change so that you do collect the smoking status at the right time, and you update it when you need to update it, and the blood pressure is there, and the problem list is updated, and the med list is there, and you get lab data, and you get electronic data, just so you can then start to make the list. But once you've done that, then you can also do your quality measures and track what you're doing. Then you can also take the next step to providing safer care through drug-drug alerts. So we're now learning to play these songs. And what the beacon communities represent is now you start to get the jazz bands. Some of them are, you know, little trios, and some of them are, you know, big brass bands. But the music has to play well with each other. We have to start putting together each group doing its thing, but swinging with everybody else. And that's what the beacons are representing. It's that not just putting the pianos in the office, not just playing beautiful music, but playing beautiful music together. And we're going to hear a lot of wonderful, wonderful stories, wonderful music out of the beacon communities. And you know, I hope that I can't wait for the day. And I have incredible optimism that the day is near, that the time is now for us to be starting to play this music all across the country. So thank you for the work you do. And I just want to say one of the things that has been so gratifying, and again, you know, maybe this is a microcosm, right? Every beacon, every community out there is a microcosm of what's happening nationally. And I got to say, federally, it has been such an incredible pleasure to be able to have everybody aligned around that central goal of each group doing their piece, whether it's from the technology side, whether it's the health IT work that we're doing, whether it's the payment side with CMS, and on the goals with the Partnership for Patients and the Center for Innovation. It's just been a wonderful opportunity to collaborate around shared goals. And that's the people you work with and around that shared goal is the biggest gift that we could have. So thank you all.
Farzad, thanks. Joe?
Thanks. I think the first thing I want to say is simply congratulations. When I think about the work that you're all doing right now, the pioneering work that you're taking on, and when I think about the milestone that you're celebrating here, I think and hope that you all pause and take a moment and appreciate what you're doing and how important it is. In a nutshell, we're watching you, which is sort of an ominous thing to be saying from my, my current position, but we're watching you in a friendly, constructive, collaborative sort of way. We're watching you very closely because we realize that we rely on innovators like all of you, pioneers like you, to help us understand how these theories that we talk about ad nauseum, these high-level strategies and visions for the future, will actually come to fruition at the front lines. So the concrete work that you're undertaking, the day-to-day battles to figure out how you make the transition from today to the future is really, really crucial. It's an asset to the nation, and I have a lot of gratitude for that and know that my colleagues at CMS do as well. It seems to me that the conversation we're having all the time right now, whether it be in fora like this one or within our federal meetings or in the private sector, it seems to me that all of these conversations have a subtext. And the subtext is about, and you've heard the terms here already several times today, it's about levers. It's about strategies. It's about, again, these theories of what we think will actually stimulate or trigger change on a national level. And at times it's a little bit uncomfortable, I think uncomfortable for all of us, because we do run the risk of getting trapped in conversation and not thinking about how effective these different approaches to implementation will actually be. When we think about CMS's role in particular, when we think about what we're trying to stimulate, the change that we're trying to trigger, of course we think about one lever that will come as no surprise to you, which is payment. And I do want to talk about that for a moment here today. But we also think increasingly about what might be called technical assistance, or the science of how we actually make change, the science of how we improve systems continuously. And so, while I want to say a few words about payment and share with you some late-breaking news, which I think is actually quite important and will be of great interest to you, I also want to take a moment to dwell on this question of how we're actually going to transform the system, and not just in pockets, in the innovative work that groups like you are doing, but across the country, how we're going to actually take to scale what works. So first, a word on payment. I think that we all know that CMS, of course, thinks about payments in a variety of different ways. We think about payment incentives, of course, and there are a number of payment incentive programs, most recently hospital value-based purchasing, that are rolling out. There are billions of dollars in incentives, billions of dollars at risk coming down the pipeline. And so this is a crucial piece of the payment discussion. But equally important, and perhaps of more interest to groups like this one, is that we have a set of new elaborate models of payment and coordinated care delivery, things like bundled payment, medical homes, and ACOs. And with respect to ACOs in particular, of course, there's been a lot of recent discussion about the proposed ACO rule. We've heard from many of you, I'm sure, related to the Medicaid Shared Savings Program, what we're calling in shorthand MSSP right now. And I can't really speak about that in any kind of detail, as you know, during this comment period. But what I can tell you is that the Innovation Center at CMS, this wonderful new jewel in the crown, as Don Berwick calls it, this wonderful new center for generating opportunities for rapid learning and innovation around tests of new payment and care delivery models. The Innovation Center is today introducing a series of exciting new tests to actually deepen our knowledge about new models of care delivery. And I had a set of remarks prepared and then got cleared to share this with you here this morning. So I'm going to be sort of reading from a script a little bit just because I want to make sure that I get this exactly right. There are three things in particular that we're announcing which I think will be very interesting to you. The first is something called the Pioneer ACO model. And the Pioneer ACO model is a model that invites experienced groups experienced in coordinated care, or groups that would view themselves as accountable care organizations at this stage, to join together and work at a more rapid pace, a more aggressive pace, to see the kind of change in terms of improving care outcomes and savings that we're seeking. The first 2 years of this program will have higher levels of shared savings and higher levels of risk than what's outlined in the current rule. And in the third year, there's the opportunity for those organizations that have been successful at demonstrating savings and successful at improving outcomes for patients and families to move toward a population-based model. So this is the place where organizations that viewed the rule and said, we can do more, we can do better, we can push harder, the opportunity is bigger here. This is the place where we invite them to come and join us and to thrive. The second item that I want to share with you is something called the Advanced Payment Program. And the Advanced Payment Program is really, I think, a response in some respects to the early feedback we had on the Medicare Shared Savings Program, which said that people were worried about the capital that would be required to introduce the infrastructure, the foundations, that will actually be necessary to be successful under this proposed rule. And so what this is a proposal, and right now it is a proposal. We're just exploring this concept, but exploring it very, very seriously. The idea that we'll have an advance on shared savings that would be expected as a function of being a part of the Medicare Shared Savings Program, that organizations would receive this advance, allow them to invest, make the capital investments in infrastructure and care coordination and IT and all the things that they'll actually need to succeed. And then the thought is that effectively the money would be recouped through the savings that would come going forward. The plan for the use of these payments obviously is something that's going to need to be detailed very significantly. So again, without saying that this is a firm decision at this stage, we do know that unquestionably we will need to require very serious plans for how these funds will be used. But we think that this is hopefully a meaningful and constructive response to some of the feedback that we've had. And we'll be looking for comments on this approach through June 17th and expect to hear from many of you on this piece in particular. The final piece, a piece that I've been closely involved with and I'm very excited about, is what we call the Advanced Development Learning Sessions. And this is essentially a set of 4 intensive learning sessions focused on the content that will be necessary to prepare for new models of care coordination. It will be an intensive curriculum where organizations will come together and executives, importantly executive teams, will come together and join us to really understand what it'll take infrastructurally to stimulate the change we're talking about. So certainly healthcare IT and data platforms will be a part of the conversation. Certainly questions about how to assume and manage risk will be a part of the discussion. Certainly discussions about how you do that painstaking work of actually improving care will be a part of the discussion. There'll be 4 sessions, as I said, the first on June 20th. And I think it's important to note that these sessions will not be focused on the Medicare Shared Savings Program specifically. Again, we can't talk in specifics about that program, but we'll really prepare people for the ACO experience generally, this experience of providing coordinated care. It is certainly also not a prerequisite that organizations have to have been in an ACO type model beforehand before they join this work. This is, again, a preparatory opportunity. So I think 3 really exciting and interesting opportunities that we're sharing with the world here today, and really welcome your feedback on and your leadership on. I think in many cases, a lot of you will have done the work that we're talking about here, will be the models or the mentors when we talk about the healthcare IT platform that we're trying to build in particular. But we also encourage you to take part in the learning and exchange that these programs promise. That's the payment piece. Let me just speak briefly about the other side, which is this question of how we actually do the work of driving change at scale. And I think this is something that is a function of a very strong feeling which is coming from CMS, which is that payment isn't enough, incentives aren't enough, and we have case after case to demonstrate that to us. Certainly we have to create the environment to stimulate change, but we all know, and certainly the clinicians and the leaders in the room here know, that the work of actually doing change is very, very difficult. It takes time, it takes attention to process, it takes attention to detail, that I think, frankly, the world at large, and maybe sometimes we in the federal government, don't appreciate fully. So what we're saying with a new series of programs, one of which the Partnership for Patients Farzad referenced, what we're saying is that it's time to actually think about creating safe spaces where we can work intensively with organizations on the actual work of driving change. The Partnership for Patients, I think, is a great exemplar here. As Farzad said, what we announced a little over a month ago now is an effort that seeks to reduce hospital-acquired conditions by 40% of what's preventable in the next 3 years, and seeks to reduce readmissions by 20% by targeting preventable readmissions in the next 3 years. So this is really significant, really bold. The way we think it's going to get done is not simply by saying to people, thou shalt, not simply by saying, here are some incentives, do this or you're going to be in trouble, but actually by making an unprecedented investment in this work of improvement. There are up to $1 billion invested in this program, $500 million focused on community care transitions through the Community Care Transitions Program, and as much as $500 million associated with work in the hospital to improve the quality of care and care delivery. That funding coming directly out of the Center for Innovation at CMS. So I think that what this represents is attention to this hard work of making change. And I would invite all of you again to find opportunities to learn more about that work and to plug into it and to take advantage of it. Without this focus on how change actually happens, what we'll do is create fear and excitement and anxiousness, but we won't actually map the process of getting from today to tomorrow. Don Berwick, my boss at CMS, often says, making people afraid doesn't make them able. And so this is the able-making part of what we're trying to create. And again, we need you as leaders in this work. Let me point you to a place that you're likely to want to go, which is the website for the Innovation Center at CMS, which is responsible for introducing these programs I described to you. It's innovations.cms.gov. Lots of information there about information sessions that will be happening today, including national calls and opportunities for you to learn more. So let me just finish where I started, which is simply to say thank you, congratulations. As you can tell, there's a steady stream of activities and opportunities that are coming your way. As I discussed with Anne-Marie before we began here today, part of our job is now to actually make sense of all of these opportunities, I think, for all of you, to create a narrative where you can understand where you fit in, where you lead, where you learn, where you take advantage of what we're introducing here. And so that'll be part of our conversation here in the weeks and months to come. But thank you very, very much again, and we're watching you.
Thanks, Joe. Thank you all, Joe, Aneesh, Farzad, for those opening comments. And I'd like to, maybe I can start this discussion.
Mix it up, man. Let's mix it up.
That's right. By taking, Aneesh, a comment you made at the beginning, which is that, look, if you're able to free up data and combine that with incentives to use it effectively, you can get some substantial transformation. And
yes.
We've seen that in lots of industries. We haven't seen it happen so quickly in healthcare, and a lot of the initiatives that you've been talking about, the ACA and all these other steps, are really intended to fill that gap and help healthcare get there too. I think, though, it can seem like, and this goes to Joe's last point about helping people think about where they fit in, maybe it can seem like to some providers like a lot's going on at once. There are a lot of different programs out there, new initiatives from CMS, ranging from bundled payments to incentive payments to initiatives related to safety, the new ones that Joe announced today, which sound very interesting from a standpoint of supporting ACOs, as well as everything that's going on in the private sector now, where there also are many efforts to try to move in this direction. So do you have any general advice for providers about how they can go about making sense of all of this and focusing, keeping the focus where I think they really want it, which is on better care for their patients, but taking advantage of this increasing range and scope of initiatives at the same time?
Well, maybe I'll start, and I'll let my colleagues say a word or two about this. I think this is the best time to be a provider at this moment because you're open to dream the dreams that you cared about when you were going through medical school or other providers that are participating, where you had these ideas for how you'd love to see the patients treated and cared for more holistically. I can't tell you how many providers I've heard say, gosh, if only I knew that I could actually get this kind of information, I would be in a better position to treat the patients that I care for, either as a group or individually. But in the previous context, you didn't have the infrastructure to support you. If you think about the market response, Mark, in a world where you optimized the current incentives system and you had an opacity of data, the software that the market produced to support you was to optimize your billing schedule or your payments, your turnaround times, and your scheduling systems. So like I was in the healthcare sector and we used to sell stuff. Man, the fastest product we could sell was billing optimization. You know, it's like, wow, yeah, that's what we got to get, fastest turnaround times on Medicaid and Medicare payments and commercial payments. So the market built better products and services. So as a physician, you had this beautiful opportunity where if you did want to optimize billing, you had lots to choose from. Now, if you're dreaming about how you could think of that patient list, that schedule that Farzad referenced, that in today's world is based on when patients call you to schedule, but in the future, as Farzad's describing, might be you proactively developing the schedule so that you take care of the patients that are in need most. There isn't an immediate off-the-shelf sort of network of support services there. You either have to create your own, which makes it frustrating as a provider, or there isn't much there. what makes today exciting is that in anticipation of these changes, the best and the brightest from Silicon Valley, Boston, everywhere else in between, who might have thought of themselves as an entrepreneur in a different sector of the economy, they're going to help make your couponing better or whatever the thing is, they're now motivated to find ways to help make that scheduling list for you so you can get the patients treated in the way you want. That means for providers who just want support, if you raised your hand and said, hey, any entrepreneurs out there who want to help me develop and prototype the kind of tools that will make me a better clinician, I will tell you they will come. Billions of dollars of venture capital from the private sector is flooding into the healthcare market. Entrepreneurs that were thinking about all kinds of things are now saying, maybe this health thing is kind of an exciting area. I can make a little bit of money and I can help to improve the system. Just raise your hand and folks will come to you. And with the tools that Joe just announced, the advanced payment piece and some other of these mosaic things, they'll all come around, they'll come together, but let them come to you. Start with your core gut. What is it that I'd love to see happen in my clinic or my network of clinics? And is there someone out there that could share this? We're joking around about this eBay marketplace for like, hey, or Match.com or whatever your analogy might be. Here's a vision for how I'd love to have my care organized in my practice. I will assure you entrepreneurs will be at your desk. The hard part's going to be figuring out which one of them you trust. But thanks to Beacon and other communities like programs of Beacon, you will have some structure to bringing some of those innovations to market. Do you want to amplify or contradict what I just said about it? How do you want to amplify that?
Well, you talk about really how do we take the eye on the prize, the vision that people want to go to, and how do we line that up against the feet on the ground of where people are today. And one of the lessons that our beacons have learned is the incredible value of having the prize, having the North Star, knowing where you're trying to go, and then doing something. Implementation is hard work, but it's a gift because it gets you grounded in what's the realities of today, and you can stepwise, incrementally. You don't have to do it all in a day. You just start, and you start building, and you start working, and it's hard work, but it's rewarding work. And that's how change happens, a step at a time. And that's what our beacons here have learned, that you can cover very long distances a step at a time.
Yeah, I agree completely and think that, it's probably our responsibility to create the narrative or tell the story of how an organization might begin and might kind of navigate all of these wonderful, exciting opportunities that are created by the Affordable Care Act. And as I say that, I'm thinking to myself, it's probably not a story. It's probably many stories. And I think we have to come to terms with the fact that there is no set process. There is no set approach. Everything is so reliant on local circumstances, levels of experience. So there needs to be some kind of stratification. But I think what we really need to begin to do and do urgently is start to capture the stories of how organizations got from point A to point B. I think we're doing a good job now at starting to shine the light on successes. But that's very different than saying, here's where this organization was 3 years ago, and here's what their first quarter looked like, and their 7th quarter looked like, and their 12th quarter looked like. Really understanding that pathway in some detail and getting into some granularity, I think, is very, very important. I think that the Partnership for Patients, in a nice way, is actually pushing us, forcing us to think about how organizations can get engaged with all these exciting programs. And I'll just point you to the work on care transitions that's happening right now around the country. I think you're about to see a first attempt at kind of describing all of the different ways that organizations can get started on care transitions and coordinated care, which start with thinking about readmissions, thinking about discharge planning, thinking about having the systems in place that all of you are working on to actually coordinate the care experience, and then move all the way over to really coordinated models of payment that require a lot of systems transformation, like an accountable care organization. So I think we're beginning to tell that story, and would encourage folks to stay tuned for that.
Right.
And we'll talk about some of those stories in just a few minutes. We talked about the provider side and all the opportunities for providers and many of these payment reform initiatives. Let me ask you about the consumer side for a minute. So consumer patient empowerment is also something that's gone along with more effective use of information technology in other industries, where people are now buying their books online, or they're not even buying books at all, they're getting them electronically, or buying their shoes online. I guess they aren't getting their shoes electronically yet, but that's probably coming. And in all these cases, people are changing their behavior in big ways. They're doing it because they can get what they want more conveniently. They can get a product that's better tailored to their needs, choosing from a much broader variety than in kind of traditional stores. And they've saved money as well, so lower costs too. And those have been big drivers of these changes in other industries. Are consumers or patients becoming as empowered? Are they as big of a part of this national health IT strategy as the provider side we were just talking about?
Look, I got to tell you, this is something that I want to just make it very clear. The president has always believed in a theory of change that involves the bottom-up grassroots empowerment story. That's why we were so pleased that Brother Mostashari over here included patient engagement in meaningful use. It was amazing to me. I had the honor of serving as sort of the implementation tech guy with Walker over here and others, and we listened to physicians and health systems testify, hey, we get this meaningful use requirement that a patient's entitled to a copy of their medical record electronically, and they're like, we don't do that. Like, we've spent all this money on IT, and it's like, some of us give thumb drives, and maybe you could log into a website and maybe look at your stuff, but you can't take it with you. And we're like, that's not how we're going to play. This information's going to flow. And the president, in a speech where he ended the combat mission in Iraq to the disabled veterans of America in August of last year, kind of a big policy speech, said in a little bit of a side note, by the way, veterans, I'm challenging the VA to liberate your personal health information, to give you the ability to have a copy of it on your own terms. I was told, I wasn't at the speech.
Was it a blue-colored button?
It was a blue button. And it was the second or first, perhaps loudest applause line of the speech, at least by the speechwriters who were giving me the feedback afterwards. And 275,000 veterans, defense, active duty military, and CMS beneficiaries are doing this. And a whole ecosystem is now building around making use of this information. It starts off very administrative data, and it will get better. The power of the internet is a governing philosophy. It's rough consensus running code. Let's get started. We'll start liberating this piece, and now pharmacy data is in, labs in. So yes, we want to have these sort of payment strategies and meaningful use rules, and we've got some legal frameworks to support this. But this president's about kind of this bottom-up mentality, so you don't know what's going to happen when you liberate some of this stuff. Now, it also means the VA publishing an unprecedented amount of quality data. Lead by example. You look at the VA's data.gov submission on the quality of care measures. Colodner's in the house. This is a lot of it built on his infrastructure. This is leading by example, liberating that data. I'd love to see the healthcare system go beyond what's required in hospital compare and publish that kind of information. When you start to see that fuel, new opportunities will emerge to provide the kind of information a patient needs to make the right decisions. I have no clue today if we get a referral, if my little girl needs to get treatment, I have no clue other than trusting the judgment of the pediatrician where they should get that care. Mark, we do not think it's that far in the future where we will be empowered with better quality and cost information to be able to complement the recommendations and to see us as an empowered member of this ecosystem making those decisions. I'm very excited about that future, and I think that has a great deal of promise. And you'll see some of this in the Beacon communities that are engaging on patient engagement specifically, and Aaron will have that in the discussion today.
I think that it's absolutely critical. For all of you in the Beacon world, you know the incredible power it has when you're trying to do governance and you have stakeholder groups, hospital, and everyone's digging in about what's right for their organization. And you say, all right, folks, time out. What's best for the patient here? The incredible power, right? Am I right? The incredible power of saying, let's think about what this feels like, not to your workflow process, but to a patient. What does this feel like to a patient? when they can't get, and when you say, sorry, you know, I'm not, you know, you can't get your record, or I'm not going to send your record to the other hospital. You're going to have to do this, you know, MRI with contrast again. What does it feel like to that patient?
It doesn't feel good, Farzad.
Does not feel good. No. So, thank you, brother.
Mixing it up a little.
So, so I think having patient-centered design and thinking about the systems we're designing from a patient point of view is incredibly powerful. Liberating the patient data through whatever policy means, as Aneesh and Todd have talked about, you know, giving people a copy of the records, giving them access to their records, patient education material, reminders to patients, after visit summaries. These are all part of meaningful use. These are all incredibly powerful. But I think as we move into the world where it's not just about the IT systems that clinicians have and hold and how they interact with patients. It's about now we move into population health management and how we're going to get behavior change and the consumer e-health marketplace and the incredible pace of innovation there, which dwarfs and leaves behind anything we could possibly do on the, you know, on the enterprise side. Gaming and social and, you know, all this, you know, amazing stuff. That's where I see incredible opportunity for innovation and improved health.
Yeah, I mean, maybe I shouldn't be in the prognosticator business, but I would predict that 10 years from now, 15 years from now, when we look back on this era, what we'll say is we created a context for change that was important and crucial, and those are the types of things that we're talking about here, but that the greatest innovations, the greatest changes were driven by the consumer. And that's what actually ultimately transformed the system. As an example, I've been working on patient safety for the last decade. I led IHI's campaigns on patient safety, the 100,000 Lives campaign and the 5 Million Lives campaign. And at that time, when we sort of finished our work and assessed where we were, the big gap, the big failure was that general awareness of issues of safety was still actually quite low. The public had heard the stories. There were 200 million media impressions, but when you ask them, what is patient safety? What are the types of harm that are possible when you come into the organization? There was really very little in the way of cognizance of that. Now, 6-7 years later, what we're finding is that individuals not only are more aware, but they're actually arriving armed when they come into the organization. They have discharge plan templates. I was in Arkansas last week and saw from 50 different hospitals the different discharge plans that are being used. They have medication cards, and it's all built on this foundation of access to data and access to information, which all of you are pioneering. So I just think in that space and for every serious problem, sort of recalcitrant problem that we've been trying to solve, the tipping point comes or the shift comes when suddenly the public says, we care about this, this is our problem, and we expect more. At that point, it makes everybody's job and change a lot easier.
Great. Well, I'd like to ask your help now in mixing it up with these guys. If there are any questions or quick comments from the audience, please raise your hand. We have some microphones going around. When you get the mic, please identify who you are when you're asking the question.
Hi, my name is Sharon Canner, and I'm with CHIME, Chief Information Officers for Hospitals. And my question is this. I have no doubt that...
You got a lot of work to do.
We do. I have no doubt that CIOs will embrace these advanced payments, this pioneer program, this executive training. And I heard numbers of 500 million, 1 billion. My question is this 2011 money? Is this hopefully, or is this 2012? I'm really very interested in the funding of all of this.
Well, the nearly $1 billion that I referred to in association with the Partnership for Patients, which is focused on improving patient safety and improving care transitions. $500 million, the Community Care Transitions Program, which is seeking to engage thousands of communities around the country in developing these models of care coordination. That solicitation is already on the street. It's already possible to apply for those funds. We hope to have similar solicitations out for the activity that's focused on in-hospital improvement later this spring, with funds beginning to hit the ground in the fall. So we're talking about opportunities very, very near term here right now when it comes to those two pieces. And I mentioned again the advanced development learning sessions that I talked about will be starting in late June. So those opportunities to connect, again, it's all right here around the corner, imminent.
One little suggestion to the Chime membership. This is an era where they need to think mostly about a portfolio approach where they'll be buying off-the-shelf stuff where you need to know about money. But equally important, I would argue, is how to integrate novel concepts where early-stage companies, entrepreneurs, even existing firms that are launching new products might say to a Chime member, I'll partner with you. We'll go in at risk, or we'll go in basically as a beta or an alpha. Will you onboard some of these new capabilities? I would argue it's important for your membership to think broadly than beyond, hey, I got a bill from a vendor and how do I pay the bill? It's actually thinking a bit more in that innovation context. How do we as an enterprise allow for some experimentation and novel application development? Because some of the best ideas may come in the form of very low cost to no cost collaborations. And please ensure that your group is thinking about that. May not be a traditional model of how they handle their buying.
Great. Thanks. Another question in the back.
Hi, John Houghton, Medical Information Officer at Covisint. First, when you guys were talking about patient engagement, it reminded me 30 years ago I was up at NIH as a patient with bone cancer and had a canvas bag that was locked with my medical record in it, and somebody forgot to put the lock on it, and I was unzipping it and pretty much took a trip to the principal's office on why I was looking at my medical record. And now John Galen, gosh, I think 5 years ago or even more, started a whole patient advisory group that it was instrumental in helping with the design of the new hospital. And so change does definitely happen. But the question that I have is how to, along the lines of how to get started. And we're seeing, at least from our vantage in the commercial area, a lot of people are focusing on doing all the hookups and then saying, okay, now let's do something with it. And it seems that the successful ones are focusing with saying, here's one discharge planner, here's one physician, here's one patient. Let's see what that looks like, and now see what hookups are necessary. And just how you guys from the policy perspective can reinforce the quick, simple trials where you can afford to make mistakes quickly.
It's just such a crucial point, and you know, it is about process, and everything that we're talking about here by way of infrastructure is amplification of successful process. In terms of how we actually create an environment that supports that, I think of this partnership for patients as a great example. What we're doing here in the hospital setting before a dollar hits the street is we're introducing a set of getting started activities where we're essentially saying to organizations, if you can't do this, if you can't do these three things, if you can't manage this for 3 patients in a week, then it's going to be awfully difficult to think about it for your whole patient population. And so the advanced development learning sessions for ACOs have that same spirit. Essentially what we're saying is, this is your chance to understand what it's really going to mean. And it's going to be hard. And you know, I actually don't think we will have succeeded. I don't know if Aaron will agree with me on this, but I think we won't have succeeded in the advanced development learning sessions if we don't discourage a few people, which is sort of a funny thing to say. But I actually think that we have to get people intimately familiar with just how hard this change is. Not so that they say, we can't do this, we're going to walk away, but so that they say, here's where we need to start. We got to get the basics down first. We have to really understand what this means at a leadership level first. So to me, that's actually where we need to go.
If you have time maybe for one more quick question.
Hi, I'm Julie Cantor-Weinberg with the College of American Pathologists, and I was in this very room back in January when one of your colleagues, Dr. McClellan, had a fabulous session on personalized medicine and health IT. And pathologists are really at the leading edge of figuring out what personalized medicine means. That's really been absent from your conversation here today, and there's no better patient engagement than, you know, specializing treatments for patients or having them avoid harmful treatment because of the genetic expression. We know that we'll be able to give people down the line, better lifestyle counseling and the like. So I wanted all of your thoughts on how the great advances in personalized medicine fits into that, because I feel like it's been strangely absent from this discussion. Thanks.
Well, let me just clarify. I don't view it as strangely absent. I think if you hear the goals that Farzad outlined, the Beacon communities have set, if you set the outcome objective, it's not really discriminatory about the path to achieve the outcome. In fact, the beauty of Beacons is that if the goal is to cut readmission by X percent, or it's to improve asthma management Y%, or to address the heart campaign to keep people healthy, it will allow for the kind of experimentation about what will the local community say is the most effective way to get there. And one may be a little bit of an early adoption of some of the personalized medicine that you're describing. It's not suggesting one way or the other. Our emphasis is on the verb, not the noun. So you don't, if we sat here and listed all the nouns that are active ingredients to the successful model, I think we would kind of be in the picking winners and losers kind of failure side of the equation. If it's about the outcomes objective and creating the conditions where opportunities can be thoughtfully introduced, tested and validated, and then hopefully scaled, we've communicated our policy approach to do that, and nobody should feel left out because your particular noun hadn't been asserted. It is very much a possibility in the context of what the communities are trying to do. And if it's not, you should reach out to the community and say, hey, I could help achieve your outcome objective in a way that maybe you hadn't thought about this. And I would imagine Aaron and the folks who are engaging with the community leaders, they'll find a way to get those ideas heard. Am I overstating that?
That's great.
Well, I'd like to thank our panelists for an excellent kickoff discussion of National Health IT Strategy. Thank you all very much.